Welcome to a presentation about posterior shoulder instability. Posterior shoulder instability can stem from pathology or problems with the labrum, capsule, and bony architecture. It may also stem from excessive movement of the humerus in the glenoid fossa or shoulder socket. Most shoulder instability is anterior, with only 5% being posterior. This pathology most commonly affects men in their 20s. Symptoms of posterior shoulder instability may include pain, apprehension with certain movements, and weakness. Pain is generally located at the back of the shoulder and can be diffuse or deep. Pain and apprehension are often felt in shoulder internal rotation, flexion, and adduction. This will also be a possible position of instability, especially as the shoulder becomes fatigued. So what causes posterior shoulder instability? This disorder may begin with microtrauma or repetitive motions with the arm outstretched in internal rotation. An example of this is blocking in football. Posterior shoulder instability may also occur after a posteriorly directed traumatic event with the arm raised and rotated internally. Some patients may have posterior instability without precipitating trauma, which could be due to variations in the individual's anatomy. Other musculoskeletal problems to consider may include shoulder impingement, biceps tendon irritation, a slap lesion, or a rotator cuff tear. The clinician should observe and assess for obvious dislocations, visible asymmetries of the upper extremities, muscle atrophy, and swelling. Active and passive range of motion should be symmetrical. Scapular winging or asymmetrical tracking may also be observed. Crepitus may occur with internal rotation, and the posterior joint line may be tender. So how does one diagnose posterior shoulder instability? The two most sensitive tests for posterior shoulder instability are the Kim and jerk tests. The posterior apprehension test is another possibility. Imaging may also provide valuable information about structural abnormalities. Physical therapy plays a crucial role in the treatment of posterior shoulder instability regardless of the type of injury. Both chronic and acute instability can be managed conservatively. Considerations for treatment should include the patient's goal and prior level of function, the physician's recommendations, comorbidities, soft tissue healing time, and pain-free exercise. Immobilization may be recommended by the physician. The major goals of therapy include restoring posture, scapular stability, shoulder strengthening, and neuromuscular re-education. The picture at the top left depicts supine serratus punches, which are an example of an early scapular stabilization exercise. On the bottom right, you will see a closed chain stabilization on a Bosu ball with perturbations, which is a much more advanced exercise for a patient with posterior shoulder instability. When conservative treatment is not an option or has yielded unsatisfactory results, surgical procedures become the treatment of choice, after which physical therapy is needed to return the patient to their desired level of function. One common surgical option is arthroscopy to repair soft tissues, remove bone, or add bone when necessary. More complex procedures can be used for more involved cases. These patients would come from the referring surgeon with a protocol for the physical therapist to follow. There are specific criteria for athletes returning to sport, which you can view at your leisure. Thank you for watching.